Hello, hello, hello. Happy Thursday, everybody. You probably are wondering why I even bother saying that, and because I think every single time you hear my voice, well, actually, no, that's not true. Never mind. I need more coffee to wake up. I hang out with you on Friday, so it is Thursday. It's not Friday, and I'm very, very excited for so many reasons today. The first is actually the return to the discussing stage of a VMR legend, Umbish. Umbish and I have been trying to make this session happen for a long, long time, and the reason for that is that she is a very, very busy, soon to be subspecialist, actually. And we tried very hard to make this happen in her intern year, but Ambush has been a CP Solvers Academy member approaching 2 years now. And this is long, long, long overdue. So Ambush, maybe we can hand the mic to you for you to update folks on where you've been, what wonderful things you've been up to, and we can then introduce everybody else.
Hey everyone, happy Thursday. Good to see you, Ravi, and all of my people from the CP Solvers community. Really excited to be here. Also nervous. The last time I was here, I was sitting in the match cycle, not even knowing what the virtual morning report culture is like and being exposed to it for the first time. And I really like being vulnerable and learning from my one of my mentors, people who inspire me, Ravi. As for my background, I am an international medical graduate from Lahore, Pakistan, and I moved to the US a year and a half ago to start my internal medicine residency training at the University of Wisconsin in Madison. And I am interested in cardiology. Let's see where life takes me, but I love medicine and I love learning from you guys.
And for those of you who don't know, the video series on Instagram that I don't have access to because I'm banned from I banned myself from indulging is really inspired by Ambush's great work and lives on to this day. I'm very, very excited to have you here with us. We also have a guest presenter. Oye, I'll hand the mic to you to introduce yourself and tell us a little bit about the backstory of why you're here.
Thank you. So my name is Oye Kweju Abioye. Call me Oye. My first name and my last names would start and end with Oye. So, you know, easy to just say Oye. I am a PGY2 internal medicine resident at Allegheny Health Network. Very interested in hematology and medical oncology. Um, Coincidentally, this case is also,
Oh,
shouldn't
don't
give
tell us,
up.
don't tell us, don't tell us.
Shouldn't give up, too much information, but maybe. Uh, I will call him Dr. Rizai because that's what I call him. Dr. Rizai is an attending at Allegheny Health Network as well. I had presented this case during one of our clinical reasoning sessions, which typically happens every Friday. And he graciously asked that I come present it here. And I was like, of course, I would love to. So that's why I'm here. It's such a pleasure to be here. And I hope to be here more often as well.
Wonderful, wonderful. That is so cool. Thank you for the sneak preview. By the way, Ambush, I think this is a he-monk case, just in case.
So,
Very, very glad that you're here. And I think what better showcasing your program than one, your participation, two, the fact that Austin is part of your program, and three, your awesome, I was going to say hoodie, but your awesome jacket, which is representing you and your program so well. Yeah, indeed. But representing the CP solvers are two of our Academy legends. Doing the scribing is Magnus today. I'll hand over the mic to Magnus. Say hello.
Hello, everyone. My name is Magnus. I don't have a jacket with my name on, unfortunately, but maybe I'll buy that soon.
Yeah, I think
Very happy to
so.
be here.
We got to get Academy jackets for everybody someday in the future. The shipping costs alone are probably prohibitive all across the world right now. The
Just
return.
stop going to the Ritz and then we can have them, you know?
If you don't get that joke, you got to subscribe to rlrcpsolvers.com. Yeah, just for the humor alone. For the return of the teaching points queen. Hello, Parisa.
Hello, everyone. Good morning. I haven't done Teaching Point for a while. I'm so excited for doing that. Yeah, and thank you, Oya, for being with us and presenting your case.
As is everybody, Parisa, who's been listening to VMR for a long time, they know they're going to get a great recap at the end. Those of you on YouTube, my apologies for the 5 minutes of dilly-dallying, but we'll be laser sharp and focused now. Mike, to you, Oye, to take us away.
course, thank you. So our patient today is a 70-year-old male who comes in with scrotal swelling and pain. This has been going on for a few months. He has had no preceding illness, no history of trauma that we're aware of, no other symptoms. This is the very first time he's having, this sequence of events. The pain and swelling has progressively gotten worse over the last couple of months, according to what he tells us. He, however, doesn't have any dysuria, he doesn't have any hematuria, no frequency, no urgency, no urinary symptoms at all. About a month ago, he had gone to the ED of a neighboring hospital. He had a scrotal ultrasound there, actually, and he was told that he had epididymolysis. He followed up with his PCP, got a couple of rounds of antibiotics, actually. This didn't help. He continued to have the swelling and then the pain. I would say, got about 2 or 3 rounds of antibiotics prior to actually coming to us. Yeah. Otherwise, his review of systems are basically negative, and this is our patient.
What a fascinating start, Oya. Thank you so much. Yeah, I'm curious what thoughts are crossing your mind.
That's a very interesting presentation, and I'm not gonna lie, I was hoping that it's not a hemonc because that is my weakness. So, all right. So far, what I'm understanding is this is an old gentleman, and while you were talking, Oye, the first thing that I was thinking of was an infectious etiology of a scrotal presentation, and then you talked about the chronicity of it, and that's when I started deviating away from an infectious etiology, and I did think of epididymoarchitis. It's pretty common in older men, and then you were also talking about some of the red flag features that would also indicate towards whether this is something urgent or whether this is something that has been going on for a while. It is giving more of an insidious picture at this time. And I guess it is safe to say that if this person has undergone multiple rounds of antibiotics, safe to say that it is less likely that the etiology is infectious at this point. So I would lean towards other buckets, inflammatory, malignancies or structural abnormalities.
I completely agree with you, Umbish. I think it's very powerful to reflect on, in addition to everything you said, that there's no other extra scrotal features to this disease. And I think that's true for the vast majority of people um, who have unilateral scrotal conditions. So whenever you have a unilateral scrotal condition, the base rate would tell you that epididymoorchitis, an inguinal hernia, or very rarely, but very morbidly, testicular torsion dominate the landscape. But as is true with leg diseases, the moment you realize the patient has bilateral leg disease like swelling, you start to realize that yes, there are some common local conditions like venous stasis. But when both legs are affected, you really have to pass a glance towards the possibility of a systemic issue. So for me, I think a key question is it a unilateral or bilateral scrotal discomfort? Because the probability of a systemic disease dramatically increases in the context of bilateral scrotal concerns. There are, however, some rare and really interesting conditions that cause a strictly focal bilateral scrotal condition, but I emphasize that that's a really key distinction. Um, it is powerful that the patient hasn't improved with antibiotics at all, and I agree with you, the negative predictive value of that is very, very high. And so as we hear this case, I think anchor yourself in the reality that most of the time, scrotal pain is a local condition from three local diseases, epididymoorchitis, hernia, and torsion. And the open question for him is, since he is progressing, is it bilateral? And if it is bilateral, how does that change the calculus? But we have yet to sort of examine him, and so we'll see how that evolves. All right, Oya, Mike, to you.
Thank you. Okay. So going on to his past medical history, our patient here has a history of HFpEF. He has CAD, has had a cabbage done a couple of years ago, has AFib, has CKD stage 4, hypertension, hyperlipidemia, type 2DM. He has a family history of heart disease in his father and brother. Otherwise, no other significant family history that we could elucidate. He's retired, he lives with his wife. He doesn't take alcohol. He's a former smoker. smoked for about, has a 25 pack year history of smoking, but quit about 10 years ago, thereabouts. Um, he uses marijuana multiple times per week. Um, with regards to his medications, he is on Eliquis, aspirin, atorvastatin, clopidogrel, Lasix, semaglutide, and sacubitril valsartan. Those are the medications he's currently taking. He has no known allergies.
Amazing, wonderful. You cannot keep cardiology away from the cardiologist, Ambish. Oh yeah, this is a great gift to our future cardiologist. How does this rich history influence your thinking, Ambish?
When you said cardiology, it kind of made me think along the lines of cardiology. And now I'm thinking if somebody has a complex history, I'm also thinking towards symptoms of heart failure, where their body can have swelling, and it can also oftentimes present as scrotal swelling. And I would think that if somebody has progressive scrotal swelling, it could also be the cause of pain. And
Mm.
Oye did say that the pain was not acute in onset, it was progressive in nature. So I would have a little bit of a bias towards this system in particular as well. So now I'm bringing that a little bit up higher on my differential, and I guess I would learn better when I assess this patient to see whether it is just localized scrotal swelling or is it coming from elsewhere or spreading.
Your ability to communicate so much information with such precision and essentially in a minute is spot on. And I agree, I'm right there with you. I think the most common cause of bilateral scrotal disease outside the scrotum is decompensated congestive heart failure. The vast majority of those patients have a significant lower extremity edema, and so the question is that present or not? I also admire your ability to really realize how you make progress in a case like this. You make progress in a case like this by visualizing the abnormality that the patient is telling you. And the truth is that scrotal diseases rise to the surface.
Mm.
Unlike the abdomen and the chest, most of scrotal pathology you'll be able to visualize with your eyes or palpate with your hands. And so the major progress in a case like this is to get that physical exam, though the context here is very helpful. We know there's heart stuff, we know it's been protracted, that it's been refractory to interventions. And so those contexts are certainly colorful. But the most important intervention for any concern that is outside the chest and the abdomen is to do the physical exam. Unfortunately, in cardiology, cardiologists do love the physical exam. And I think an EKG, troponin, and a POCUS sometimes takes it a little bit further than that. So yeah, I'm right there with you. We have a interesting context to analyze, and I'm really, really curious what the exam shows. Mike, to you, will you?
Of course. So I put on my gloves and it's time to examine this 70-year-old male who's come to me with scrotal swelling. Um, just checking his vitals. He's afebrile. Um, his heart rate is 92 beats per minute. His blood pressure is 158 over 97. His respiratory rate is 16. He's saturating pretty well at 97% on room air. And his BMI is around 34. And just looking at him, he appears uncomfortable. He seems like he's in pain. He's diaphoretic. Um, HENT, pretty much normal. Cardiovascular examination, um, pretty benign right now. He doesn't have a JVD. Pulmonary examination for him, normal pulmonary effort, normal breath sounds. Abdominal examination also pretty benign. His abdomen is soft, no areas of tenderness that I can elicit. His bowel sounds are present. And now going to his GU examination, genitourinary examination for this patient. Um, as I begin to start examining him, he tells me he's had pain and swelling mostly on the left. Um, his examination also shows an enlargement of the left hemiscrotum.
Hmm.
I feel a mass, you know. I can't exactly make out what it is, but there's definitely a mass in that area.
Hmm.
Neurologically is pretty much intact. MSK for him, no lower extremity edema. His skin is also pretty much, fine. So yeah, that is his examination.
Fascinating. Wow. All right, Ambish. Yeah, what's going on in your mind?
So I do have a few follow-up questions. Oye, did you notice any bruising in that area?
No, no bruising.
And then on the rest of the body, no signs of bleeding, no bruising.
No, good question. No bleeding, no bruising on any other areas of the body.
And then I do have one more question about the previous aliquot. I'm noticing that this gentleman had his cabbage many years ago. I understand they have AFib, and I'm noticing that they're on triple therapy. They're on Eliquis, Plavix, and aspirin. Is there a reason why they were on all three agents?
I wasn't able to confirm this, and in the acute setting, we didn't exactly want to like tamper with his medications, but yes, that's something good to have noted.
I see Ravi smiling. So the reason why I'm asking this question is I have seen this situation often, and we often wonder, what is going on? Why would they be on three agents? And age-wise, bleed risk is pretty high as well, given all these comorbidities. And I'm thinking why I was asking about the bruising was I was thinking, are they over anticoagulated
Yeah.
and are they bleeding?
Mhm.
So that was why I was curious about that. But looks like they're not bleeding, and we'll learn more as the labs come back. But overtly, we don't see any signs of bleeding, so that's reassuring. And again, pain wise, I keep thinking that this pain is not acute enough that this patient is jumping. It is very, in the background, kind of a discomfort more than pain. And then now that you mentioned that it is unilateral, so that is kind of going to help us narrow the bucket, which Ravi will help us with more than I
Yeah.
can. But I am thinking you have palpated a mass. So I am thinking of a localized malignancy here as well, on top of maybe like a small mass, maybe a contained hematoma, maybe
Yeah.
a hydrocele.
Yeah, I know. I think you palpating a mass in this context is very interesting, and I think the first thing that you might do at the bedside to see if it transilluminates, which is if you shine a light to see if the light filters through, and if the light filters through, you know that the mass is probably not very dense and that it has fluid in it, and that's very helpful to suggest a hydrocele. And so transillumination is a simple test, though in the modern era, I think an ultrasound would help you make a tremendous progress. And so anytime that you see a mass, you want to image it and characterize it better than possible. And the modalities that you have are infinite. There's so many different ways, but if you're literally looking at a focal mass that's a surface, ultrasound can give you a tremendous insight. And so that would be the next step. I think the most morbid hypothesis would be that this patient has a malignancy, of course, but as you alluded to, the possibility of a hematoma and then, of course, an abscess looms large here. Um, I think it's even if we might not end up in that direction, Ambish, would you say just in general, what would be in your mind the classic presentation in terms of age of a man with a testicular cancer? What do you think about that question?
I think age-wise, he
Yeah.
does fit the illness script of somebody who would present with testicular cancer. So
Yeah.
I am thinking that he does fit that picture. And then unilateral swelling. So
Yeah.
definitely very high on my differential.
Yeah, I think it's interesting to reflect on that question in more detail about the kind of cancer. So, if you were to say, probabilistically speaking, if you know that somebody has testicular cancer, what age are they? Unfortunately, they're a lot younger than this person. So, the average age is in the second or third decades of life. And the kinds of cancers that predominate are actually germ cell tumors. So this is helpful just to compare it to the ovarian equivalent. So in ovarian cancer, germ cell tumors are very rare. They usually are epithelial tumors and usually in postmenopausal women. In men, the tumors occur at a younger age and are usually of germ cell origin. So part of the pretest probability of malignancy has to do with the patient's age. So if you're factoring in all comers, when you feel a testicular mass in a young man, in a young man, really, there are very few things that will deviate you from doing an empiric orchiectomy, just taking it out, because the pretest probability of a tumor that is a germ cell origin is very, very high. Of course, there are some ultrasound characteristics that would maybe prove another diagnosis like a hydrocele, so on and so forth. But there's, if any suspicion that it's malignant, it comes out. That's how high the pretest probability is, and that's how high the imaging. It's one of the very few cancers you don't biopsy before you remove it. Part of the reason you don't biopsy it also is the risk of seeding the tumor. So just to acknowledge that his demographics influence the pretest probability of cancer, and in all comers reduce it. But unfortunately, as you alluded to, there's a twist. And by far and away, the most common cause of a testicular tumor in an older adult, again, the rate is lower, is a testicular lymphoma. And so that has tremendous implications for how you analyze a patient like this. So ultimately, whenever we feel a mass, there's a DDX. That DDX includes an abscess, it includes hematoma. But whenever you see mass, you always, most morbid hypothesis is cancer. And if you were seeing a mass in a young, otherwise healthy man who has characteristics that might implicate on imaging, cancer comes right out. In him, it'll be a very interesting diagnostic journey. But since he is not the classic patient with testicular cancer, the pretest probability of cancer is also lower. So it becomes really, really important to study the features on imaging. The final thing I'll say is that if this turns out to be the rare possibility of testicular cancer, we say testicular lymphoma, which can be isolated to the testes, but it has a high rate of having appearance in other places. So while so far all we've been talking about is scrotal issues, I think the labs may give us an insight into reframing this problem as a subtle systemic disease with scrotal features. So a lot of work to be done, and we'll see where I can see why this is a clinical reasoning conference case now. Um, Mike, to you, Oye, for the information you have next.
Thank you. I really love the direction of the conversation because there was so much going through our minds as well when we saw this patient. So going to his labs, initial WBC was around 10,000, 10.25 to be precise, neutrophils of 71%, lymphocytes of about 18%, eosinophils of 5%. Hemoglobin was 9.9 grams per DL, platelets were 202. A CMP was pretty much, benign. Sodium was 133, potassium was 5.0, creatinine was 3.75. We do know this patient has CKD, pretty much close to his baseline. AST was 16, ALT was 9. LDH, which we got for him, was 403. His urinalysis was also pretty benign, I would say. We got an AFP at this point as well. AFP was negative. Beta HCG was negative. EKG didn't show any significant findings. And if you recall, when we started, when he had initially gone to the neighborhood hospital, he had gotten a scrotal ultrasound, which was benign. We got a repeat scrotal ultrasound at this point, and it showed an enlarged and heterogeneous left testis and epididymis with a complex left hydrocele. It was suspicious again for epididymolysis per the read. There was no discrete testicular mass to suggest malignancy on the scrotal ultrasound. That was quite surprising to us, but then again, we take what we have. Still going on to imaging, we got a CTAP. This showed diffuse retroperitoneal and pelvic adenopathy.
Yeah.
So we knew something was up. It also showed a left gonadal vein thrombosis and was suspicious for possible lymphoproliferative versus metastatic disease.
Yeah.
And then we got urology on board.
Yeah.
Eventually, our patient underwent an orchiectomy and had a ureteral stent placed. Intraoperatively, the surgeon noted that the cord was very thick and hardened, and they literally had to put that in the op notes that the spermatic cord is very thick, it's very hardened. And unfortunately, while we were waiting for pathology, our patient elected to self-discharge. He left the hospital. He did come back, but he left the hospital, and so there was a gap in his care.
Hmm.
Is it okay to continue at this point as well?
I wonder, yeah, you've given us a lot of information. I'm just curious, just to help us with pacing. Do you know how much information you have left until you reveal the diagnosis?
Um, a little bit more because he came back to the hospital a
I
week
see. Okay.
later.
I can provide clarity into that.
Yeah.
So yeah, I think from a practical standpoint, you'll have one like aliquot more of information, and then the final aliquot will be sort of like how things transpired, and then ultimately the diagnosis. So I think this would be a good time to do sort of like a more either this aliquot or the next aliquot information.
Yeah, thank you so much, Austin. I really appreciate it. Yeah, Amish, I think it's a really, really good time because we just got a lot of momentum going forward. I'd love to share to open breakout rooms for all of you to discuss together. But I think we're gonna understandably skip over a key step in this analysis, so maybe I can shed light on that. Um, uh, because this case is more complicated. But this, I think the key step here is getting that CT abdomen pelvis. And so maybe I can share the rationale for why that's a brilliant move, and then have you guys discuss in the breakout rooms the findings on that CT, which I think are a game changer. But I think if you are in a world where you're feeling a testicular mass in an older adult, as we talked about, the pretest probability of a testicular mass in an older adult is reduced. And so you might ask yourself, are you being fooled? And I think diffuse enlargement of the testis and the epididymis can fool you. And this is just a general principle about how venous hypertension can cause pressure, and that pressure buildup can look like a mass. And so, eh, because of what we talked about, the pretest probability being lower because of his age, you're all more open to diffuse pressure buildup from venous congestion rather than a collection of mass. And I think that the ultimate finding on the ultrasound isn't too surprising because of the anatomy of the venous structures. So if you're dealing with a diffuse enlargement of the testicle, especially on the left side, you really have to worry about ipsilateral venous pathology. And that is the only cause of a unilateral testicular pathology that the scrotal ultrasound will underappreciate. Because everything that we talked about before, be it a hernia, be it a torsion, be it epididymitis, the scrotal ultrasound has performance characteristics that are exceptional. So if you have unilateral testicular disease that is evading clear diagnostic confirmation on ultrasound, you really have to think about that gonadal vein being clotted. And sometimes you can catch it on the ultrasound, but other times not. And so why is the anatomy so crucial here? So it's just remember that the left gonadal vein has a perpendicular path to the IVC, meaning that before it goes to the IVC, it connects to the ipsilateral renal vein, and the renal vein then drains into the IVC. In stark contrast, on the right side, you have a straight path uh, to the IVC. And so the significance of that is a little bit complicated. So if you have any condition that is, in addition to stasis from that weird contour, contributing to hypercoagulability, here on the CT, you see many other things that can really fool you. So if you were to think about how diseases extend into the scrotum, as you alluded to, diseases can extend into the scrotum by a venous congestion from systemic heart failure, but diseases can also extend into the scrotum through involvement of the gonadal veins, sometimes asymmetrically. And if there's going to be asymmetric gonadal vein involvement, it's probably going to affect the left side more than the right side because of the additional variable of the abnormal flow of the left gonadal vein. This is a conversation we have about the legs too. Left lower extremity edema, asymmetrically so, is much more common than right lower extremity asymmetric edema because of the iliac vein being compressed by the iliac artery. So when you're seeing a left-sided diffusely swollen testicle, you really have to wonder, is the asymmetry in the left gonadal vein key here? And I had a case that I presented to Reza that had a similar phenotype to it a long, long time ago. So this is not the focus of the conversation. Hopefully, this is just a moment to encourage all of you when you have diffuse testicular enlargement, to think about venous hypertension and to think about getting a CT scan earlier. Though I'm glad that Oye and her team got it pretty quickly. And so now we're moving into a whole different space, and maybe we can talk about that in the breakout rooms, and come back in about 4 or 5 minutes. See you all soon. Everyone. So, Amish, what are you thinking? What was the conversation like?
So we had a really interesting conversation. We had um, anatomical discussions about what could be the causes. So we do think that lymphoma is a very, very plausible explanation of all of this. And then in the setting of, I think the very interesting thing that we noted was the gonadal vein thrombosis and then the pelvic adenopathy. So then that we were thinking whether they are correlated and whether this cancer has metastasized. And then Mohammed was in my room and he did mention that spermatic cord is in close vicinity with the gonadal vein. So we were thinking about how, they could be linked, and if the vein is compressed, that could be causing buildup of, and causing all of that swelling in the scrotum.
Yeah, I'm right there with you. I think that, this it's amazing. This exercise turns into you sort of have to update your problem representation to realize that the disease doesn't live in the testicle. It's being transmitted to the testicle indirectly through venous hypertension. The counter argument to that, of course, is the finding that the spermatic cord is so thick. And I'm be really curious, is it really thick because there's something wrong in it, or is it really thick because it's been chronically congested? And I don't have enough experience or knowledge to be able to tease those out. But I think, unfortunately for the patient, I think all of us have enough experience or knowledge to worry that a diffuse retroperitoneal lymphadenopathy often means cancer. And just to acknowledge the base rate is that the local tumors account for the vast majority of retroperitoneal lymphadenopathy. So the local tumors would be metastatic disease from the GI tract, especially rectal cancer, metastatic disease from the genitourinary tract, prostate cancer, bladder cancer, testicular cancer, of course, gynecological malignancies as well. And so the question is there an asymmetric focus in the GI tract, the GU tract, the GYN tract? Or is this a intrinsically metastatic process like lymphoma? And so I think it's this case is all about tissue is the issue, and I think we've made one attempt at getting histology with the orchiectomy, and I think the open question is, will that biopsy answer that? Will that orchiectomy answer the question? And is it holding the pathology that is affecting the patient and the retroperitoneum? Or is it actually a distractor because the testicular pathology is purely venous hypertension as a result of the gonadal vein thrombosis, leaving the true intrinsic disease left to be discovered in the retroperitoneum? And I think that's the tension I'm feeling, and I'm curious how the case progressed, Oye.
Of course. All right. So this patient comes back to the hospital a week later. The only reason he comes back this time is because he's having chest pain, is having shortness of breath, and he also has a severe right ankle pain. We get Dopplers. He doesn't have any Dopplerable pulses. So we do think there's another disease process going on alongside. We'd get vascular surgery on board. In the meantime, we check his CBCs. WBC right now is around 64,000. Notably, the differentials, we have neutrophils of 46%, lymphocytes of 12%, eosinophils of 1%, monocytes of 2%, blasts of 24%. He also has his hemoglobin was pretty much same as when he came prior. All other labs pretty much the same, apart from his LDH, which is now over 2,500. Um, but over the course of the days, WBC continued to uptrend. We checked again the next days, WBC was now 113,000, up from 64,000, so almost doubled. We got another CTAP. This time it showed the progression of an infiltrative process in the left anterolateral pelvis that was extending into the inguinal and anterior pelvic regions. There are also thoughts of possible Fournier's gangrene, necrotizing fasciitis at this point as well. Eventually, we get his pathology back. Thankfully, we got that the last time. And it showed a 5.4 cm left testicular mass. The tumor morphology and immunophenotype was supportive of myeloid blasts involvement. And then there was a recommendation for bone marrow biopsy. So at that point, we were able to get a diagnosis of acute myeloid sarcoma with monocytic differentiation, which was very wild in a sense because we did have a lot of differentials on our plate, but we really weren't thinking about a myeloid leukemia or sarcoma, extending to the testis, but that is what our final diagnosis was based on pathology. And, the patient was immediately started on cytoreduction with hydroxyurea. Unfortunately, he, didn't make it past a couple of odd days because he did have like some other pathologic processes going on alongside. Like I said earlier, we had to get the vascular surgery team on board, and his clinical care was pretty good, but at the same time, there was a lot going on. And I do think that week gap between when he left the hospital and came back did make a difference in his overall prognosis, considering the fact that we had to start treatment for the acute myeloid sarcoma immediately. So.
Oh, yeah, this is a very, very eye-opening case. Thank you so much. I think there's a lot to reflect on. Yeah, what are you thinking, Amber?
So I'm kind of shocked, and I'm not able to make sense of underlying physiology wise. I would like to know more about this, but I was thinking once they did remove the mass, there was massive growth of cells. It rapidly progressed. So I am thinking, what was that the source at all in the first place, or was it just a manifestation of the underlying disease? And so that was a very striking, kind of progression of the disease for me, that it became very, very aggressive. Did it convert? We think about blast crisis and all of those things, which I'm not very good with, but that was something that definitely strikingly, stood out.
Yeah, I think that there's going to be a lot of questions about this case because it's a very rare manifestation of not a decently rare condition. But I think a helpful place to start is to disentangle two cancers that often get lumped together, which is lymphoma and leukemia. So, Ambish, you looked at that CT scan and was like diffuse lymphadenopathy. I have to rule out lymphoma, right? And it turns out that the final diagnosis here is leukemia, and you are appropriately surprised. And so let me try to make an argument as to why this is a surprising diagnosis. And it all goes back to anchoring yourself in the expected location of the respective cell, leukemia or lymphoma. So lymphoma is a cancer of the mature B or T or rarely other kinds of cells, and mature cells live outside the bone marrow, circulating in the blood or living in lymph nodes. They also live in tissues throughout the body. So you cannot biopsy anything without finding some lymphocytes. The place they don't naturally live is in the bone marrow, which is why the most common manifestation of a lymphoma is lymph node swelling, or rarely tissue uh, masses. Those are called extranodal, outside the node lymphomas. Or even more rarely, you have increased circulating mature cells in the blood. So an example of each would be diffuse large B-cell lymphoma causing diffuse lymphadenopathy, classic presentation. The other example might be that you have a GI lymphoma from celiac disease causing extranodal lymphoma, or what's confusing is having a lymphoma in your blood. Um, Acute leukemias, in contrast, are not found in the body and are instead found in the bone marrow. And so the cancer is almost always located in the bone marrow. And the bone marrow pathology spills over into the blood when there's a large amount of it, but there are no intrinsically mutated cells within the blood itself. Every single cell that's in the blood in the case of leukemia originated in the bone marrow and just fell out. So if you're making and trying to understand lymphoma versus leukemia, even though we lump them together, this could be a lymphoma. Lymphoma is a cancer of mature cells that live outside the bone marrow, and leukemia is a cancer of the stem cells that live inside the bone marrow. And the beautiful thing about medicine is there crosstalk? The answer is of course. Many lymphomas eventually metastasize to the bone marrow, and that is a marker of severe advanced disease in almost every kind of lymphoma. Classically, for example, if you have bone marrow involvement in Hodgkin's lymphoma, that's like the final stage of Hodgkin's, the worst possibility. The question for that space is more familiar to us. We're very commonly used to saying, oh, this patient has lymphoma to their marrow, that very bad diagnosis. What you're seeing, Ambish, today is the mirror image for leukemias, which is a leukemia that is initially beginning the opposite of where it should be. And this is a very rare presentation, a fascinating one, and one that I actually saw in residency. And in my case, my patient's leukemia began in his ileum, and he had an ileal mass that was biopsied, and it was full of leukemic cells. And a month later, almost probably identical to this patient, a month after his illness, it becomes clear that he also synchronously has a mutation in his bone marrow. And so it's a reminder to us all that there are likely stem cells that can mutate into leukemia, not just in the bone marrow, but everywhere in the body. They're present in microscopically small numbers, but they can start off a cancerous cascade. And it's unfortunately very true that a myeloid sarcoma, which refers to a collection of premature leukemic cells that initially develops outside the marrow, it often um, signals the concurrent or impending development of the exact same neoplasm in the bone marrow. Now, if you can teach me or convince me how his scrotum and his bone marrow are communicating, even though pathophysiologically they're oceans apart, I don't think anybody knows. It's absolutely fascinating. But I'd encourage all of you to sort of take this case as a simple reminder that lymphoma, mature cell body, leukemia, immature cell bone marrow, and lymphomas go to the bone marrow a lot. Leukemias start in the periphery very, very rarely, but it's very well described and often has a horrific prognosis, as in this case. So that's my uh, attempt at trying to simplify what is a complicated concept. Um, yeah, I'm curious what questions you have about it, Ambish, and what reflections you have to share, and then we'll learn from Oye and how she's processing this case.
Thank you, Ravi, for breaking it down and making us all understand it. I love how you categorize things, outside in the body and then in the bone marrow. So I'm already picturing the underlying, pathology in my head. My question is, do you think that the orchiectomy kind of triggered the cascade? Like, do you think that was it just a mere coincidence, or do you think that the process evolved after the orchiectomy and there was like a link there?
Yeah, all I can tell you is I know that if you have myeloid sarcoma in your scrotum, which we know this patient has, the probability that you're going to develop a tumor in your bone marrow uh, synchronously that it's happening is very, very high. And then within the next month or 2 months, you're gonna develop that cancer. So I don't think that any proceduralization has any bearing on the outcome. I think that it allows us to, the fact that he got the orchiectomy is a beautiful thing because it allows us to confirm that he actually had a myeloid sarcoma. He probably would have succumbed to his leukemia that eventually developed regardless. And what could have happened is he may never have gotten the scrotum removed, and it would have remained purely speculative as to what happened in his scrotum. Um, I'll end by encouraging all of you to read more about the missing link, which is plasma cells. And we'll tell you that Alec presented a case to us that teaches us that plasma cells can do the exact same thing we talked about. So we're all used to plasma cells in the bone marrow causing multiple myeloma, but there's the entire world of what's called plasmacytomas, which refer to a collection of plasma cells outside the bone marrow, either in the bone or in the soft tissue that cause a story similar to this. So, Hemoc is a fantastic, really, really rich intellectual space. And Oye, what thoughts, reflections do you have?
Yeah, and thank you so much. This was a really fascinating, topic to discuss. And also, I loved how everything was broken down. I thought this was a very great case for me to learn because it helped me to realize that you cannot just anchor diagnosis on, what you thought about prior. You have to keep thinking, expanding your differentials. And that was beautifully modeled even during this presentation. The important things for me that I learned was, not all scrotal swelling is an infection or an hernia. And also extramedullary AML can present before leukemia shows up in the blood, like you rightly pointed out. And this was my first time of seeing something like that happen, actually, and also, like you also pointed out, we need tissue to get the bottom of like a diagnosis like this. So when the swelling feels wrong, you do need to get tissue. Um, and finally, for me, I think another thing I went to read about is the fact that we do have the testis is a sanctuary site, and so we have the blood testis barrier, and this can limit chemo penetration. So, um, this is something to think about when we have to think about the modalities of treatment. Could radiotherapy be a better option in this case? I guess that's why hem-onc is such an interesting field for me because we get to think about all the different modalities of treatment that's, it's possible. And like you said, I know initially we had thought about testicular cancer, but we talked about the fact that the age doesn't quite fit right. I thought that was interesting. I was just smiling because I was like, that was one of the first things I thought about when I saw this patient as well. If we're thinking about testicular cancer in a 70-year-old male, that's odd,
Mhm.
And so yeah, I thought it was very interesting and thank you for allowing me to present this case.
Oh my gosh, I can't believe you're thanking us. You shared with us such powerful wisdom, and we got to see how a very, very shrewd and wise resident presents a case, and also how a future cardiology case sniffs out, future cardiologist sniffs out the bread and butter medicine. I wish it was such a treat to discuss with you, and I thought you were cool, calm, collected, to the point, accurate, and I think that your future patients are lucky to have you, even if it's not taking care of hem-onc issues. Um, I'm just going to take a moment to I can't implore you enough to consider checking out and consider presenting and sharing your cases just like Oya did. And one perk of presenting your cases frequently in this space is inviting you to hang out with us and nerd out a lot. And one of the things that I wanted to share with you is a brief conversation, is just to reinforce what we talked about now, which is the idea of cancers that can develop anywhere. And here's a short list of cancers that can show up in any location in the body. I think melanomas are notorious for showing up anywhere, including the bowel. But in terms of liquid tumors, we talk about lymphoma and we think about lymphoma in everywhere. But you're seeing, I think, the concept that Oye is teaching us, which is that these conditions can also show up literally anywhere, including having leukemia in your scrotum. Um, the beauty about the Academy is if you show up and present your cases, we deep dive into these topics behind the scenes. So really, really implore you and ask you to consider showing up, presenting your cases so we can learn from each other and then learn even some more when we hang out behind the scenes. So thank you, Oya. Thank you, Ambish. Thank you, Magnus, for keeping up with the scribing of a complex case. And we now go to the teaching points queen. Right to you first.
Thank you, everyone. It was a phenomenal session, and I couldn't agree more. Hem-onc is one of the best subspecialty out there. Starting with the case today, we had a patient who came in with scrotal swelling and pain, and we start off by thinking about the basics and the branching for point for sclerotal disease are usually thinking about are they unilateral or bilateral. Same thing for we use the same framework for lower extremity edema. And for example, when we are facing unilateral swelling, it usually reflects a local problem, something like epididymitis, inguinal hernia, or testicular torsion. But when it comes to bilateral swelling, we generally think about a systemic process, most common one, decompensated heart failure, although there are some bilateral pathology which are rare. And we learned that at this point, careful physical examination is the best way to differentiate between these buckets. And then when we are considering a testicular mass, precise physical examination and looking for a transillumination would be helping us, because if there is a transillumination, we are thinking about fluid recoloration and hydrocele. But if it doesn't, we are mainly thinking about hematoma, abscesses, and malignancy. And then in that case, as usually ultrasound will be a great diagnostic confirmation. When one important exception to this rule is that sometimes testicle might be enlarged diffusely, specifically on the left side, and then ultrasound might not giving us a clear explanation, and we need to consider venous hypertension, which sometimes it's underappreciated. And then we touch base on the venous anatomy, and the left gonadal vein, usually it drains perpendicularly to the left renal vein versus the right gonadal vein, which drains straight. And this angulated longer course, which makes it more prone to congestion, which is exactly the same thing we observe in the lower extremity edema, and the concept that a left iliac vein is compressed when passing forward. But generally, when we are thinking about venous hypertension and the venous stasis in that unusual places, we need to think about also hypercoagulability, and then try to frame why this congestion in that area is happening, then mimicking the masses. Talking about testicular cancer, we know that in the male population, the germ cell tumors are most common, but their epidemiology is mainly in 20s and 30s. Testicular lymphoma might happen in the older population, but it is not really likely. And then in this case, we reached to the point that we had retroperitoneal lymphadenopathy, and we all know that it is that almost translate to malignancy, but it's important to frame it based on the origin. It might be the local tumor metastasis, someplace like GI, rectal cancer. It might be gynecological malignancies. And last one, it could be lymphoid malignancies. And differentiating among these, we need tissue. Then we entertain a really fascinating topic about lymphoma and leukemia. We know that the lymphoma are mature B cell or T cell, and they would circulate around in the body. And the most common presentation is lymph node swelling, something like large B-cell lymphoma, or extranodal tissue presentation like GI lymphoma. But we also learned that a mature lymphocyte could circulate in the blood. And we learned that when lymphoma reaches the bone marrow, it is the advanced disease, something like Hodgkin disease. But in contrast, when it comes to leukemia, they are immature stem cells, and they're originating from the bone marrow, and the blast usually spill over into the blood. But there are rare, fascinating situations like here that it could start outside the bone marrow first, and it creates a entity like myeloid sarcoma, which is a mass of leukemic blast developing in the tissue. And it usually signals that the conkeridone impeding leukemia, it's happening in the marrow. And the same phenomenon, it's happened for the plasma cell myeloma, that could also generate a focal masses outside the bone marrow. And then put everything together, the scrotal mass shows us the venous anatomy problem, the lymphadenopathy, and at the end with this amazing hematologic reasoning. Thank you so much for being here and present your case.
How did it feel, Teresa?
I love this case so much. It was
Yeah,
amazing. Yeah,
yeah,
I
I'm
never
proud.
thought about leukemia and lymphoma in that way. It's
Yeah,
always surprised me how you break down.
yeah, you captured, I think, the essence of the case so well. But I really appreciate that You walked us through the journey step by step and the clarity and then the summary at the end. Absolutely superb. Thank you all for a really wonderful hour and look forward to seeing some of you next time. Bye.
Thank you. Look forward to seeing you at our programs.